All right. Hello, everyone, and welcome. My name is Kayla Fowler, and I'm the Director of Experiential STEM Programs for the Douglas Project for Women in STEM at Douglas Residential College. Thank you for all being with us today, and hope that you are healthy and safe during these times. During this time of social distancing, the Douglas Project for Women in STEM and Douglas Residential College is hosting a Women in Public Health speaker series, highlighting the interdisciplinary nature and impact public health has in our daily lives. Today, we are honored to have Dr. Susan Kirk, a designated institutional official and Associate Dean for Graduate Medical Education at the University of Virginia Health System, where she is also jointly appointed as an Associate Professor in Internal Medicine and Obstetrics and Gynecology. She is a graduate of Douglas College and Rutgers Medical School. She completed her internship and residency and was chief resident in internal medicine at the University of North Carolina, Chapel Hill. At the University of Virginia, she completed a fellowship and is currently board certified in endocrinology. Her areas of clinical expertise are in diabetes and pregnancy and transgender health. Just a bit of housekeeping before we begin. All attendees have been placed on mute for the duration of this discussion. If you have questions, please send them via the Q&A option at the bottom right of your screen at any time. We'll be taking pauses during the presentation to answer questions and for discussion. And it is now my privilege to turn it over to introduce our guest speaker, Dr. Susan Kirk.
Thank you so very much, Kayla. It's a real pleasure to be here. It gives me pause to think about how long ago I was at Douglas. I started in 1979 and graduated in 83. So I started as a 5-year-old, of course. But Douglas means so many things to me and really positioned me so well to be in the leadership position that I have right now. So I'm just going to start with a big thank you to Douglas for getting me to this point, and a thank you to the project for inviting me tonight. So we have a relatively small and intimate group. I'd like to start out so that you know exactly what's going to hit you. I have 43 slides. There's unfortunately a fair amount of bullet points on those, but I've built in 4 or 5 spots where we can stop and reflect and pause and ask questions and give comments. As I said to Kayla on Friday, some of this, especially when it comes to medical school and residency, I'm familiar with, and I'll share my experiences. But you're living the life of an undergrad who's being impacted by COVID. And so what I've read in the literature may not reflect your actual experience, and you should feel free to speak up and share that information. So without further delay, I have no financial disclosures. So after I left New Jersey, I went to North Carolina, and then really for the bulk of my career, I've been in Charlottesville, Virginia. And Charlottesville, like New Jersey and Douglas, is not that far away from the Appalachian Trail. And this has been a really great place, especially in the pandemic, to go in a socially distanced way and get outside. So if you think about sort of the Appalachian Trail as a metaphor for a career path, 2020 really looks like this. And this was from an actual camera on a trail that I hiked. The bear wasn't there when I was there. But, the bear can be life-threatening. It can be also really immovable. And you have to decide, are you going to wait? Are you going to go around it? Are you going to retreat? And so I think everybody who's been in some sort of trajectory this year has just had to stop and really rethink what their plans are. So these are the topics that I plan to cover. Very quickly, the demographics of the U.S.
So yes, it is being recorded. We did have two other questions as well. One of the questions specific to this, and you've kind of answered it a little bit, but I guess if you want to expound on it as well, is how has medical education changed as a result of the pandemic? Like, what have you seen in your specific role? And are there any ways in which you see these changes possibly being permanent?
Oh, those are such great questions. And I didn't plant them, I promise, but those are coming up next and at the end of the talk. So if you want to go back to sharing, we can move into the medical
Awesome.
school impact. All right, so on cue now, the impact on medical school and then postgraduate training. And I'll just say as a definition, postgraduate refers to post medical school graduate training. Most of you and anybody who ever watched Grey's Anatomy knows what an intern or a resident is. So postgraduate training really refers to that group of people. So next slide. So the biggest impact on the applicants to medical school, so these are people who are hoping to go to medical school, maybe some of you who are not yet in medical school, really have to do with a loss of opportunities for shadowing or volunteering. This is really the way that you distinguished yourself or made a personal connection. It's not infrequent where someone would say, hey, I'm interested in going to medical school. Can I spend some time with you in clinic? And it's really a way to get the foot in the door. And that door slammed shut pretty significantly in March, and it has not yet reopened. As I talked about in the first section, the STEM classes have been much more difficult to move online. And they're just now, at least at the University of Virginia, starting to open up in a way so that lab experiences are in person again. And what we don't know at this point, and again, these are for applicants, is the impact of choosing credit, no credit versus a letter grade. And at the University of Virginia, the students were given that option to choose that. And many of them went to their advisors and said, what should I do? You know, because if I choose credit, no credit, it might impact my GPA. And most medical schools and training programs have pledged to look at applicants more holistically, but they don't have a lot of experience in doing that. And so what I heard one of the deans at UVA say is anybody who gives you a definitive answer of you absolutely should do it this way is lying. They do not know what they're doing. So use your best guess. And if it's a class where you're pretty sure you're going to get a high grade, my personal recommendation would be to go for the letter grade in that. If it's one where you're worried about it, absolutely take the credit, no credit. But nobody at this point really knows how this is all going to play out in this current cycle of applications. Next slide, please. Oh, and for those of you who were planning, you've probably noticed that the MCAT was canceled 8 times between March and May. So it made your life a little bit difficult to know when you should take the MCAT, and it delayed a lot of people actually applying. So for students who are already in medical school, they faced similar actions and decisions as their undergraduate peers in the lockdown. They were migrated out of their classrooms, and those who were actually in patient interactions or clinical clerkships were sent home. And this, within a week or two, their faculty and medical school faculty often are taking care of patients and even less versed in creating online learning. They were switched to that sort of mode. I will say, and I'm speaking at the University of Virginia, but this is what I'm hearing from my peers around the country too, that although students are considered a somewhat vulnerable population, right? I mean, do you feel at risk, but you've got a faculty member saying, well, you really should go take care of that COVID patient. If you're worried about a letter of recommendation or a grade, you might be inclined to say you want to do it even if you're worried about it or scared. So I think people were worried about the vulnerability of students and residents. However, the real decision for why people were kept out of the environment were, in the beginning, we just didn't have enough masks, we didn't have enough gloves, we didn't have enough gowns. And so the decisions were made to send sort of one doctor at a time into the room to see a patient, rather than our usual group of medical students, residents, nurse practitioners, an attending physician. That was the reason why people were kept out of it, because you are all, our medical students are going to have to learn how to take care of patients with COVID. So you can't be excluded from it forever. And now our medical students are allowed back into the environment as long as our PPE remains stable. Next slide, please. At the University of Massachusetts and other places around the country, and I chose this one because they published it, they made a rather significant decision at the end of March to move up their graduation by 2 months. And Massachusetts, like New Jersey and New York, was overwhelmed with the number of COVID patients, and including healthcare workers. They didn't have enough people to actually take care of the patients who were sick. So rather than continuing in their education until May and sort of graduating, an ad hoc committee was formed that looked at each student individually and said, ready to go? And if they thought that the students had demonstrated competency, they graduated them at the end of March, and they allowed them to begin work early. Now, this sounds like it's a relatively easy decision, but you have to consider that malpractice and state legislature and boards of health had to create this new position, and they called them contract laborers at the University of Massachusetts Medical Center, in order for this to happen, because this is not necessarily a job description that most people will insure for malpractice. But they were described as incredibly helpful and instrumental. They freed up the more experienced residents to go take care of the COVID patients while they took care of the many, many other people who are in a hospital for sort of more normal reasons. And so if this continues, I could see that other places would pivot to this sort of a solution in the future. Next slide, please. There was a lot of talk about this at the University of Virginia. They ultimately decided to not graduate them early. And what you had was 800 medical students at home, incredibly frustrated that they had nothing to do. And so they reached out in a number of heartwarming ways to stay busy. They delivered food to the homeless. They created a mask task force where they accepted masks from the community. At one point, when we ran out of hand sanitizer, they collected the bottles so that we could make our own. And just anecdotally, our pharmacists started to make hand sanitizer, and the alcohol that they used was from a bourbon factory down the road. And so that product still exists. Whenever you use it, you feel like your hands have been on the underside of a bar. But it kills germs, and it specifically kills the virus. And so we were happy to have it. But the medical students who are now back at work did not remain idle. And I think that's true for many other places around the country. Next slide, please. So in terms of medical residents and fellows, this was a bit more complicated. So these were healthcare providers who were already at work. What happened to them completely depended on how much COVID was in the community. So in Chicago and in Boston and in New York City and in places in New Jersey, where there were so many patients and so many sick healthcare workers who had to potentially quarantine if they were exposed to a sick patient for 14 days, they ran out of people to take care of it. So there were stories of psychiatry residents who had not done any intensive care training since they had been a medical student, suddenly finding themselves in an ICU having to take care of the patient on a ventilator. And one of the things that I really love about my job and about this community is that we share our learning. You know, there's very little proprietary information. So those of you who went through the worst of it first reached out to everybody else and said, listen, this is what you do. And so for those of us who are in sort of a delayed surge later, we were well prepared. And we actually knew that we could take a gastroenterology fellow or an orthopedic surgery resident and place them in certain areas due to their sort of skills and competency, so that nobody felt like they were taking care of the patients in a way where they were unprepared. However, the impact in Virginia was that the governor shut down all elective surgeries. We closed our clinics for up to a month. And so if you're a resident or an intern, you're depending on patients. They're your educational material. They're your real life lab. And so there were a month or two where they had no learning whatsoever. So their training was markedly reduced. Next slide, please. And the ACGME, which is the Accreditation Council, which accredits all the sponsoring institutions, recognized this, and they created these three categories. One, which was business as usual, and there were some institutions that remained lucky enough to stay in that, not very many, and certainly not now. The second was that your clinical learning environment was impacted a little bit, but not so disrupted that people couldn't go about their training in their specialty program. But the third one, and unfortunately, we're now seeing institutions choose that all over again, or for the first time, is this stage 3 or this pandemic emergency. And at that point, all the requirements except for having to be adequately supervised, having appropriate PPE, and making sure that you didn't exceed your duty hours, which as a resident is 80 hours a week. Otherwise, as an orthopedic resident, your requirements for training were dropped so that you could go help out other people. And that was, again, a very rapid shift in an organization that normally takes a year or two to make small changes. They made that change virtually overnight. Next slide, please. So at UVA, we were never overwhelmed. We have a 600-bed hospital. We've never had more than 40 at a time. In the community, we've had some, mostly in congregate living. Some of our meat packing and poultry plants, unfortunately, are very vulnerable populations of incarcerated people, patients in nursing home. But the sickest patients were actually transferred from the larger cities up near Washington, D.C. and Richmond to come to our ICU. And we were incredibly fortunate that we had a whole new wing of the hospital that was about to open up to take care of transplant patients and orthopedic surgery patients that had never had a single patient in it, that we quickly converted to COVID units. And so we were able to sort of separate out our regular patients from the COVID patients, and that made everything much safer. And all of our didactic education really has been dependent on what our governor has said. How many people can be in a room? How much can you gather? That applies not just to social events, but to our educational environments as well. Although we felt in the beginning that our emergency medicine residents and our internal medicine residents were at the highest risk of exposure, what we've seen is that most of our exposures have occurred outside of the hospital, either when visiting family or socializing. As long as we've had appropriate protective equipment, our residents have been safe within the hospital. Next slide. Oh, yes, and that was what I said. A lot of, I understand it. People are tired of this and they want to go visit their family, and it's been very difficult for them to stay focused on the safety that they need. So, deep breath, and I'll let Kayla sort of sift through the questions and see if there's anything. I have not yet answered what I think is permanent. That's still coming, but hopefully that answered the question about medical school.
There were some questions in regards to your specific specialty, and how all of this pandemic has possibly also affected your specialty and how your experiences on the ground. If you could just share some of those experiences as well.
Yeah, so thanks for asking that question. So I actually have 3 different areas where I concentrate my clinical activity, and they've all been a little bit different. I help take care of high-risk pregnant patients, so I don't do any of what I say from the belly button below, so I don't actually deliver the babies, but I take care of things like diabetes or hypertension or thyroid disease while the woman is pregnant. And obviously, that's a very hard population to take care of virtually. They need to come into the clinic and they need to have somebody listen to the baby's heartbeat and make sure that the baby is growing. So although we can do some of that, and especially my part, like looking at blood sugars online, I see that group of patients once a week. And um, I wear goggles, I wear a mask, not a N95, which keeps the particles out, but just sort of a surgical loop mask, which that's the same as what many of you wear when you go to the grocery store. Wash my hands constantly. And I'm not at all worried about the patients. They're screened, although, as we know now, up to 40% of people are asymptomatic and spreading the disease. So the screening is, if anything, it's sort of falsely reassuring. But I wash my hands a lot. What I'm most worried about is being in a workroom with 6 other doctors who are all talking on the telephone. And that's probably where my biggest risk is. But we try to minimize it as much as possible. My general endocrine has actually lent itself to this mixture of in-person and telemedicine. My patients with type 1 diabetes are in sort of a higher risk category. They're considered somewhat immunocompromised. I give them the option of seeing them on telemedicine or coming in person. My older patients who maybe are not as familiar with a computer or a bit hard of hearing, they like to come in person. Also, Charlottesville is surrounded by a very rural and a not particularly affluent community in the surrounding counties. Many of them don't have the bandwidth to have a telemedicine appointment. And so for that reason, they'll often opt to come in person. And then my third group, and probably my most interesting, are my transgender patients. And most of them, I would say at this point, are opting for telemedicine. And that's a whole different talk in itself. But a waiting room can be a incredibly anxiety-provoking, sometimes even hostile environment for a transgender patient. And so to not have to navigate that and just be able to talk with me one-on-one and then later sort of go get their labs checked is the experience that most of them are choosing at this point. And I do believe that that will probably be permanent. So I'll talk a little bit more about that at the end.
We just have one additional follow-up question as well. If pregnant patients are also at a high risk for COVID.
Right. So it's a great question. Initially, it was a no, and then it was a yes, and now it's like we're not really sure. And so the CDC has sort of changed its guidelines. If you do the math, we are now 10 months into this pandemic, and so not a lot of people got pregnant or delivered a baby at this point to know what the effects are on the fetus. And so if you think about Zika, we know really well that if you are pregnant and you contract Zika, it's not at all good for the baby. We don't know the data for that in terms of SARS-CoV-2 at this point. What we do know is that if you're a pregnant woman and you get sick, you are more likely to have complications. And a sick mom is never a good thing for the health of the unborn baby. And so we are treating them as high risk, but we don't know at this point whether or not there's going to be any risk for sort of congenital malformations. And we don't know if there is, we don't know a lot about transmission from the mom to the baby while it's in utero to know if the baby has been born. In China, the data that's emerged has suggested that the babies actually do okay as long as the mom doesn't get too sick when she has it. Okay, so thank you for asking that question. I'd love to talk about my job. So, all right, the last two things are relatively quick, and then a couple of follow-up things that I added on at the minute. So in terms of applying and interviewing for positions, you know, I have witnessed this personally as we've interviewed applicants for our endocrine fellowship this fall, and I've talked to a lot of students and residents, but you can go online and get 100,000 different tips as to what you should or you shouldn't do. So I picked a couple that I thought were helpful, but you should also talk to people who have done it already because they are going to be your best source of information as to what worked for them. So next slide, please. So nearly all interviews are virtual, and the national organizations have recommended this. The Association for American Medical Colleges, the ACGME, they don't want the applicants to be vectors of disease going from institution to institution and spreading it. And unfortunately, without these elective rotations, which served as auditions, there really isn't a great way at this point to distinguish yourself as an applicant. We know that the number of applicants or applications is up sharply. We don't know if the number of applicants is up sharply, although if you look at times of economic recession, more people tend to go into medicine as sort of a safe field. And I know a lot of my younger colleagues are going back to work to graduate school. So I think there is an actual real number of applicants as well. But applications are up by 35%, so more than a third at the University of Virginia. And although internal medicine residency applications are up by 10 to 20%, and of course that's a fixed number of people graduating from medical school, so not the same option for people to go into it. There are some fields like physical medicine and rehabilitation where the applications are up 50%. So the competition is definitely fierce in a year where you can't necessarily demonstrate in person just how wonderful you are. Next slide, please. So in terms of virtual interview don'ts, and this is just a stock photo, I don't know why this was a failure. It looks like she's in a restaurant, I'm guessing from the latte, but she could be in a bathroom, so I'm not sure. But anyway, this was somebody's image of somebody who's not having a good interview. Next slide, please. So distractions come in many forms. I am violating this right now. I've got a dog that's sort of pawing at the door, and I've got a kitten that's sort of running across my lap. But you don't necessarily want to have a distraction where the person interviewing you is going to remember the distraction and not you. A horrible story at the University of Virginia. Somebody interviewing for a chairmanship in a department, her cat sort of leaped and scratched her lip, and then she was like bleeding, and it was just, we all remember that. She didn't get the job. So I think she may not have gotten the job anyway, but it's unfortunate that that's the thing that we remember about her. And I don't know how many of you know sort of David Brooks. He's the conservative commentator. He's from the New York Times. He's on PBS. I can't stop looking at his bookshelf because it's color coded. But I'm not sure that that's good. If he were interviewing for something, I would be spending less time thinking about what he said and more time thinking about, well, why are those orange and what are those blue books? So you also, and sorry, I've demonstrated this completely, you don't want a faulty internet or poor lighting. You shouldn't wing it. And Kayla and I didn't wing it. We actually did a bit of a dry run, so even that isn't fail-proof. But if you have a friend or family member where you can actually practice answering some questions in this strange, surreal way, you should. Turn off your other apps, not just your phone so that it's not a distraction, but turn off the other apps in your computer. Most people have 11 devices running in their household at any one time, and that's going to drain your bandwidth. So, and I'll admit that I'm wearing a pair of big fluffy slippers right now, but you should dress as if you're actually going to an in-person interview. And psychologically, there's data that shows you actually do better if you dress up. It puts you in a mind frame that you might not otherwise be. Now, I heard of one surgery program that actually made the applicants stand up and show what they were wearing on their feet. I think that's incredibly creepy and jerky as well. So I would not go to that place. But just, you might have to stand up for some other reason. You know, you have to plug in your computer. And so you want to make sure that you're dressed from head to toe in a way that you feel good about yourself. Next slide, please. In terms of the things that you should do, I think this gets a little bit more to the warm and fuzzy. Next slide. The don'ts are easier than the do's, but you should ask yourself these questions in advance. What do I do best? What are my unique talents? What advantages do I have? What do other people say I do well? What resources do I have available? And what's my greatest achievement? And I've been surprised that at the end of most of my interviews, whether it's for a training position or just a staff member in my office, I always ask the person, okay, I'm going to give you the last word here. What's the lasting impression that you want to leave with me of yourself? And so many times the person's like, oh, gee, I really didn't think about that. And oh boy, you better know what you're good at and what you want me to remember about you. So, and then of course you'll be disappointed if they don't ask that question, but really think about what impression it is and not just the basic knowledge that you might be expected to answer during an interview. And I think there might be two other bullet points on this. Oh, so know your institution and know your reviewer, but not in a fake way. So I can sort of suss out when somebody is just trying to impress me and they're like, oh, tell me about that article that you wrote in 1992. I'm like, no, you don't really want to know about that, and we've had these group meetings where there's one person that's sort of the unfortunate kid at the front of the class who's always raising their hand and asking questions, and they clearly want to be recognized, and I get it. If there's a way that you can distinguish yourself without necessarily calling attention to yourself, those are two different things. I would try very hard to do that, but do know something about the institution and the reviewer. And we always ask, do you have any questions? That's not the time to say, no, I think I've got it. Even if your question has been answered by somebody else, ask it again to show that you're genuinely interested. And I'm not going to talk about dress. I already did. I would be wrong to say that I knew what the right thing it is to wear to an interview. It's probably not the best time to wear sort of a tight-fitting leopard print dress. Because that would get noticed, but not necessarily in a way that you would want. And I recognize I'm talking to a class full of sort of female future leaders. Unfortunately, we are also judged for what we wear. On the other hand, I just completed an interview season and every single person was wearing a black suit and a white shirt or a white blouse. And I couldn't take them apart afterwards. So just give it some thought. I wouldn't obsess on it. And again, try to avoid anything that you're going to be remembered for that you don't want to be remembered for. So next slide. Oh, and this is really important. I think what struck me the most in the interviews I've conducted so far is anything that's COVID related. So many of my applicants had been involved with research projects or had volunteered in their community or had a family member who was impacted by it and were able to tell a relatively short story to say what the past few months have been like to them. That felt very genuine and was very meaningful. So that might be something that you would think about doing as well. Okay, so we're in the home stretch here. Maybe we can keep going and then we'll save the last couple of minutes for all the questions. So this is the Susan Kirk hypothesis. There's no actual research-driven data, but I think these are the things that are going to stay with us going forward. So telemedicine is a big one. Telemedicine has been around for years. It's been slow to be put to use, despite the fact that in a lot of cases, it's actually the best thing for the patient. The biggest reason for that is payment to the medical centers and to the doctors. And there were all sorts of rules that you had to jump through in order to charge for a telemedicine visit. That medicine, which is a corporate entity, I'm sad to say, made it sort of unfavorable for people to choose. The government, and specifically the Center for Medicare and Medicaid Services, changed that in March. And so now there's actually an easier way to sort of charge for a visit than you would have before. And so I think that that will make it easier for hospitals and clinics to say that they'll continue to use it. I also think that some form of hybrid learning, some combination of in-person and online in a synchronous way will be with us forever. So in the past, if medicine grand rounds was at 12 o'clock and you were really worried about a sick patient in the ICU, you would forego going to across the street to another building to listen to this grand rounds. But now we're piping in educational conferences simultaneously to all these workrooms and other smaller spaces so that everybody can participate, whether or not you're freed that hour or not. Likewise, virtual attendance at every national meeting I've gone to has doubled or tripled because people don't have to pay for travel and they don't have to pay for lodging. And it's been well done. These 3 and 4 day conferences that a society like the Endocrine Society puts on, you can attend the lectures and do all the learning from the comfort of your own home. In that case, you're not interviewing. You can wear pajamas and puffy slippers if you want to. And so I think that that although you can't beat the on-site networking and sort of catching up with friends, which was always a big part of those meetings as well, I think that that's here to stay. Virtual interviews this season will, I think, tell us whether they're here to stay or not. But the fact that we have so many highly qualified applicants that we might not have otherwise, I think it's going to be hard to back away from that. And I've just loved that these sort of super nerdy scientists and specialists in public health and epidemiology and infectious disease, they're heroes right now. They've deserved that designation for a long time. But I think that there's a much greater appreciation. And I hope that that doesn't go away. And this is maybe just a personal plea on my part, but flexibility, we're so used to hearing, oh no, we've never done it that way, or we can't do it that way, that won't work. We have found that actually it will work. And so to be flexible and open-minded about sort of the standard traditional way we've always done things, maybe we've all learned from that as well. One more, two more things. So for all of you who are considering a career in women, I would just urge you to go read this short little piece at the AAMC. That's the Association of American Medical Colleges. And this is a very eye-opening piece about how COVID-19 is threatening the careers of women in medicine. And it's really the entire pipeline, right? Because it's that graduate student or that medical student who has kids or a sick parent, and that responsibility is falling disproportionately on the females of the family. So whether you're just entering your career or you're a mid-level person and all of a sudden you have to go to part-time, you're teaching your kids sort of online education rather than writing your grant or your manuscript, there's a real concern that the fact that it's taken us this long to really sort of reach an area that's close to parity, not necessarily in terms of salary, unfortunately, or leadership positions, but in terms of actual numbers in the profession, there's real concerns that we're going to lose a lot of ground from this. And so we're counting on all of you to still go into medicine and make sure that we shore up our numbers. And for all of you men who might be listening in too, we're counting on you to help out your female partners at home. So, and then I just thought I would share this. This has been in the news. If you could go to the next slide. There are 2 vaccines now. Interesting, Pfizer today came out and said they were 95% effective as well. But we are going to have emergency authorized use at the University of Virginia for 3,000 people to get it. And what I've heard about it is we're going to follow the National Academy of Medicine guidelines that say that healthcare workers and those that are most at risk for serious disease or death will be the ones who get it first. followed by essential workers and others with sort of comorbid or pre-existing conditions. We're really looking at the summer before the general population and potentially healthy college students would be eligible for this. So this is not the time to let down your guard. Wear your mask, wash your hands. There is still a lot that we have to do before we get to the point where we all have the immunity that we can sort of overcome this. The other thing that I heard, not to discourage anybody, but this is sort of like your MMR, what you got as a kid at the pediatrician's office. There's an initial vaccine and then a booster shot. If you get the Moderna or the Pfizer, you have to get the second shot of the same one. You can't mix and match. And the couple of people I've heard of that actually were in those trials, you get really sick with a second shot. So you should not get your second vaccine on the day before you have your final exam because you're going to feel pretty crummy the next day. But the immunity actually looks like it's good at this point. There's still a lot that we don't know, but compared to a week or two ago, I think a lot of us are feeling more optimistic. And I wanted to end on sort of that more positive note rather than some of the other negative stuff that I had to share. And this is just the phases. Healthcare workers are in the beginning. This is available probably on most of your social media platforms at this point too. So I think I have one more slide. This is actually the Appalachian Trail about an hour south of my house. It's a lovely, lovely open space on the top of a mountain. So I hope as you're all contemplating your career, going back to that earlier analogy, that the summit is close to you at this point and that your horizons are sunny. But hang in there. We are going to get through this. And I'm happy at this point to answer any questions.
Wonderful. Thank you so much, Dr. Kirk. I'm sure there's a virtual applause at everyone's homes right now. We just had two additional questions, again, relating to your journey from attending college to going to medical school, of why you chose your specific specialty. And most of the audience here are pre-med students. So if you had any advice outside of just like COVID related things, what advice would you give to our pre-med students as well?
And I was looking at the question about the table. So maybe if you go back to that while I'm answering the question. So the first question was, how did I choose the medical school that I wanted to go to? Mm-hmm. So that's a great question. And so the acceptance rate into medical school right now is about 41%. That's probably what it was back in 1982. When I was applying for medical school as well. I was going to go to any medical school that accepted me. And I was a pretty good student at Douglas. I told Kayla I was one of the inaugural 10 students in the honors program. And so I really give a lot of credit to them for helping me develop some leadership skills. But I was really ready to go anywhere that I got in. And in the end, I got into two of the New Jersey schools. And the tuition was significantly cheaper there. That made a big difference. I have subsequently talked to medical students who have gotten into one of the Ivies and gotten into sort of some of the top tier schools and the mid-level schools. Honestly, there is a lot to be said about reputation and networking, but you're going to get a good education no matter where you go. And I ended up choosing a campus for my clinical years that was relatively brand new and was still able to get a really good residency and ultimately a job that I really love. So I chose mine based on, first of all, they accepted me. And second, I did not want to graduate with hundreds of thousands of dollars worth of debt, which the average medical school debt these days is $250,000. And then I had family in the South Jersey area. It's now Rowan, but it was part of Rutgers Medical School when I went there. And I wanted to be close to family at the time. So it really had more to do with the social factors and the financial factors than the actual training that I received. And I do feel that, medical education is relatively standardized. If you get an interview and you talk to people, talk to the students, are they treated well? Do the faculty seem interested in their education, or are they just sort of cogs in a wheel? I think, it's like none of you are probably buying houses at this point, but it's sort of the curb appeal. If you know you like it, there's probably a reason for that, and it's important to go with your gut. So that question was sort of all over the place, but mine really came down to really practical factors more than anything else.
Thank
And
you. And is this
was
the slide
there
they wanted or the one before this?
the one before that, I
Okay.
think? Yeah. There you go. Yeah, you can take a screenshot of that if you need to. There was a second part of that career question as well.
Yes, just give me 1 second. If you can give any advice to a pre-med student, what would that advice be?
So I think what I've got a public persona and a personal persona, and so when I'm public speaking, it's probably harder for you to tell that I'm a really serious introvert. But when I was in classes, I was incredibly shy, and I never felt like I could go up and bother a teacher about anything. I was more likely to sort of try to find out an answer on my own. I think that that was a mistake. If you can get to know your professors, and in some of the STEM classes, that's hard. They're large, they're taught by TAs, the labs, but if you can get to know your professors well, that really helps. They're a wonderful source of advice, and their letters of recommendation count as much, if not more, in years like this than sort of MCAT scores. And so you want somebody who's not just going to write, Susan was a really good student and she was a pleasure having my class. You really want to get to know a professor well enough that they can write you a letter that describes something that's really genuine about you. I also think that compared to when I was in school, things are different clearly, but there was a heavy emphasis on the sciences. And so I majored in biology, but I loved English. If I hadn't wanted to go to medical school, I would have been an English major because I loved reading and I loved literature so much. I think to demonstrate that passion in a particular area is more important to an admissions committee these days. They're looking for well-rounded students. And again, most selection committees can read through a resume and think, okay, this person was sort of padding their resume and that experience didn't mean that much. But if you love something and you volunteer or you've got a hobby that you're particularly passionate about, I would go with it because it's no longer physics, chemistry, and biology. They want to see that you're a well-rounded person and that you're good at something.
Oops. Thank you. And then one of the questions from before was from a student if it's okay to share your email and contact information if they have any additional questions or want to reach out to you.
Yes, absolutely. And even if you've got questions and you email me, we can set up a time to chat by telephone too. So I'd be really happy to be connected with any of you who are looking for somebody who's sort of gone down this pathway. I will say, whether it's a STEM field, which is incredibly important, you're doing the scientific discoveries that are leading to sort of patient care, or medicine, you're going into great careers right now. So stick with it. There aren't so many other places where you get to choose, what you're interested in and what area of the country that you want to live in and practice in. So it's worth the hard work. It is really hard, but I would just recommend that you all stay with it.
Awesome. Thank you so much, Dr. Kirk. Thank you all for the students that stayed and asked questions. Um, Thank you again for devoting your time. And this has been definitely on par as we talked the other day. This has been the top question that we've got at Douglas as staff mentors and staff is what are medical schools or graduate schools doing and what does that look like for COVID? So I'm hoping that the students were able to get some of their questions answered. And when I send out the evaluation, once you complete that, I'll send Dr. Kirk's information to you all. Thank you again, Dr. Kirk, and have a wonderful night.
Thank you. I hope you all have a really great, if slightly altered Thanksgiving, and stay safe.